Well, thank you very much. This is always a wonderful conference to attend. It's not my first one. I've been here a number of times, and I'm always amazed at the incredible preparation and hospitality and everything else. So I thank you again for having us here. I'm going to talk about a couple different things here that I think are potentially important in your own healthcare system. I actually think they're quite important in our healthcare system too, but let me explain as I go along why these may be some things you want to think about in dealing with some of the issues that you face with your own healthcare system. So this is just a quick and dirty outline of some of the topics I'm going to hit. I'll talk a little bit about some things we sort of know about healthcare systems. I'm also going to present a very simple model, which I'll call sort of a non-price adjustment model. There is a price in this model, but there are some other ways in which supply and demand adjust or equalize. I think the model has some lessons, and I think some particularly strong lessons for a system like yours where you do try to maintain a zero price, or at least the official price. I'll talk about some other games in town. In other words, some other ways that people have approached some of these issues. And I think there's one that's particularly interesting that involves some incentives for consumers. And it's a plan that started up in the late 1970s, and I became aware of it and spent some time looking at it rather closely. And unfortunately, it has sort of gone by the board for the most part, but I still feel it's a very interesting idea and something that could be useful in your circumstances. I'll also talk a little bit about some results of this incentive-based system, and I'm kind of tipping my hand here a little bit, but I'll also be a little bit of a post-mortem because this system is not really, does not really exist anymore in the way that it once did. And then I'll give you a few sort of references here as well. So some things that we know about healthcare systems. I think the first one is that there really is no such thing as a free healthcare system from a resource cost perspective. I mean, think about your own system. Yeah, even if the price is zero, that doesn't mean that the resources that are going into the system have no value. I mean, that zero price is sort of an artificial device, and it's meant, obviously, to make healthcare very accessible to the entire population. That's a very admirable thing, and I think most healthcare systems try to achieve that to some extent, one way or another. But we shouldn't confuse that, which is kind of an administrative decision, with the notion that somehow healthcare is a free good. It's not. It requires lots of resources, labor, materials, equipment, and so forth. And those resources all have alternative uses. They could be put to other purposes. And so there is this kind of implicit cost in providing healthcare in any system. The resource costs don't vanish. I mean, simply restricting your price to zero doesn't mean that those costs go down or that they go away. So it's important, I think, always to kind of keep that in mind, that healthcare is inherently an expensive thing to deliver, and you have to find ways to finance it. If you're not going to finance it from individuals, you need to finance it through government or through businesses. But ultimately, most of those sorts of financing come back to the consumer in one way or another. And we can talk about that maybe a little bit later. The second thing that I think we know about healthcare systems is that these healthcare costs vary considerably. I mean, all you need to do is to look at international data to see the differences in not only the absolute level of health expenditures, but the percentages spent on healthcare. I mean, our healthcare system now costs us an amount equivalent to about 18% of our GDP. That's kind of twice the percentage of most other healthcare systems in industrialized economies. So we're either doing something very wrong in the US, or we're providing a very different kind of healthcare, or maybe it's both. But the fact of the matter is there are other countries that devote a lot less of their resources to healthcare and yet get actually better outcomes, at least by certain measures. The other thing that's kind of important to keep in mind is that it's not just variation across countries, it's variation across regions, across states, even across local areas, smaller areas. We find this even within the state of Connecticut. We have 169 townships within a small state. And if you look at healthcare utilization patterns, for example, in some of the government programs, you'll see quite dramatic differences across those different areas. So that's always something to keep in mind, is that healthcare is a very heterogeneous good. It's not like peanut butter, you know? I mean, not everybody gets the same amount, not everybody needs the same amount, and so in some ways your system needs to accommodate that. Another thing that we see a lot of in the States is there's a lot of variation in these expenditures over time. So it's not just looking cross-sectionally at health expenditures and seeing a lot of differences. We also see a lot of variation over time. I don't know that I have any slides of that today, but I did yesterday in a session that we had, and it's striking how much some of these expenditures have changed over several decades. The other final item here is that there's really no right cost of healthcare. In other words, these cost differences that we observe, we shouldn't necessarily try to eliminate them all. I mean, there are lots of reasons why these costs vary. They're likely to reflect demographic factors, you know, the age composition of the population, disease patterns, the health habits of the population. You can go right down the list. There's lots of reasons why not everybody will want to consume the same amount of health care or need to consume the same amount of health care. And so we don't want to try to over-standardize healthcare systems. I think that's a mistake. And that's one reason I think it's a mistake to take a system like yours and somehow try to model it after another system. There are lots of differences here that may be important that you want to preserve. A third item here is that having a free or again, I put that in quotes because I want to use that to refer to a zero price healthcare system, doesn't eliminate the need for cost control. And in this graph I'm going to show you in a minute, you're going to see that if you try to provide, quote, free care or zero price care, you're going to have some consequences that aren't always what you want. Both utilization and the price that would actually clear the market, that would equate supply and demand, are quite likely to rise, almost inevitable, I think, that they will rise. And furthermore, any effort to kind of keep that price low in order to encourage access to care is going to simply create a shortage, and that presents its own sort of problems. So here's a simple model or simple diagram that we use in health economics classes. And what it shows is that blue line that you see is sort of a demand curve when people are uninsured. So that C equals 1 refers to what we call the coinsurance rate, the fraction paid by the consumer, paid out of pocket by the consumer. And if you have a coinsurance rate of 1, it means you really have no insurance. Everybody's paying their full cost of care. The supply curve is upward sloping, and so normally you would get the market clearing at that price of P star, and the quantity that would be consumed at that point that would kind of balance or be balanced by this equilibrium price is Q star. Now the thing is, of course, we want to protect people from the cost of health care, so typically we do have insurance. And you can show both kind of graphically and mathematically that what happens as you reduce C, it's almost as if you have a proportional subsidy. You know, if you were to have a system where you subsidize price, it would have exactly the same effect. It would rotate the demand. And in this case, what I've shown is what will happen if you eliminate the coinsurance rate. In other words, if you have full coverage where the person pays 0% out of pocket, then that demand becomes effectively inelastic. Economists would call it perfectly inelastic. People will consume the same amount of health care, the amount that they would have consumed at a zero price had they been paying for the health care, but now they will consume that amount at any price. They don't care what the price is. And that's where the problem sort of arises in healthcare systems, where you want to provide, it's this kind of conflict. You want to provide pretty full coverage to people to protect them from these uncertainties. But when you do, it puts a lot of pressure on the system in terms of costs, both in terms of the quantity of care. Notice that Q increases to Q prime, right? But also on the price. The price is going up to that P prime figure. You can also see in this figure that suppose price went up to P prime and you tried to force it back down again. Well, as you force it down, you're gonna generate a shortage. Your demand, that sort of vertical orange line, is going to be separated from that black line, and so you're going to get a shortage. And the further you push the price down, the bigger that shortage will be. So those are just some kind of basic things about healthcare markets that we, at least as health economists, kind of take for granted. Another important thing, and I'm going to illustrate this a little more clearly, is that price is not the only way to allocate healthcare. There are other mechanisms for equating supply and demand. If you think about the quantity of care, it's not just the price that matters, it's also the coinsurance rate, as we've kind of seen, but it's also side payments. If I have to make really high side payments, well, that reduces my demand for health care. If there are very high time costs, if I have to wait a long time to get an appointment, or if I go to the doctor and I have to wait in the office a long time, any of those time costs are effectively a different kind of price, right? It's not a money price, but it's something that we value and that we sometimes have to part with if we're going to get health care. The quality of care can also be seen as sort of a rationing mechanism. Low quality care is going to deter me from consuming health care. High quality care is going to encourage me to consume health care. So one way of thinking about the demand is that function in the middle of the page here, where it says quantity is a function of P and C and S and T and Z, all these different kinds of prices, if you like. It's also a function of a lot of other individual factors, demographic factors and so forth. But these kinds of alternative prices are what I want to focus on for a minute, because I think there's an interesting lesson that comes out of this. This idea is also important for kind of understanding how quote, free healthcare systems ultimately do equilibrate in some way. They ultimately do, kind of equate supply and demand in a rather rough way, and it's not always perfect, but it's usually through the adjustment of these other kinds of variables, besides simply the money price. So here's a simple illustration of this idea of non-price adjustment. So suppose we have demand for healthcare, and it's a real simple kind of linear relationship. So it's equal to this constant A naught minus another constant times times CP. Now CP is kind of an important variable in health economics. It's the coinsurance rate times the full price. Well, that's a fraction of the full price, so that's essentially what the person is paying out of pocket, that term CP. I'm also assuming it's a function of S, which is this side payment, kind of a under-the-table payment to get quicker care or better care, and the time cost. So any of those three, if you increase any of those three, it's going to reduce the quantity demanded, right? So I'm going to simplify the model by assuming on the supply side, we've got real simple supply. We've just got a constant, okay? So the quantity supplied is equal to some other constant. Oh, I didn't want A naught there. That should be, I think that should be B. No, I'm sorry. I haven't gotten to that other one. Here's the supply side. The supply side is just this constant B naught. So notice it doesn't depend on any of those other things. I'm doing that, again, to kind of simplify things. You could easily have some of these other kinds of prices on that side as well as some other factors that might influence supply. So let's assume that this supply is insufficient to meet demand if all three of these costs are zero. In other words, if we had care that was free and no side payments and virtually no wait times, well, we probably would have excess demand. And what that implies in terms of this model is that A naught has got to be bigger than B naught, okay? And in turn, that means that the difference is greater than zero. So the question is, what combinations of these three kinds of prices would cause supply and demand to equate and allow this market to clear? Well, we can do that mathematically. I'm not going to take too much time on this. You can look at this later. But what you'll see down at the bottom is that if two of these prices happen to be set equal to 0, you can find sort of the market clearing value of the third price, all right? Well, what that does is it sort of allows you to plot what these equilibrium combinations look like. I think most of you are familiar with simple supply and demand graph where you have a single point that equates supply and demand. Here we're going to have a whole surface. We're going to have kind of an unlimited number of points that will equate supply and demand, and they're all just different combinations of these three kind of prices. So this is what it looks like, okay, if you work out the math and the geometry here a little bit. So on the vertical axis, we've got this out-of-pocket price. On this axis that's projecting to the front, we've got side payments, and then this time price on the right-hand side. So all of those combinations on that surface would clear this market, all right? So you could choose, well, what kind of system do you want? Do you want, you know, kind of a balanced system where you pay some of each of these kinds of prices, or do you want to eliminate one kind of price and rely only on the other two? But look what happens in this thing if you do what you have effectively done in your healthcare system. Suppose you make CP effectively 0. In other words, the official price is 0. Well, you have the same surface, but the only points that will clear the market are along that bottom red line. And notice that what that means is it's going to entail some combination of time price and side payment. And if, for example, if you want the market to clear and you want to get rid of side payments, well, one way to do that is have real high time prices, let people wait a long time, right? Or you can do the opposite. You can try to really shorten the wait times, but you're going to have very high side payments. But notice that this is kind of, this decision to eliminate price altogether really does restrict your options. And I think that's important to understand when you're trying to devise a system that not only meets certain goals in terms of performance, but also functions rather smoothly. And I would imagine that everybody probably agrees not only your system doesn't function totally smoothly, but our system doesn't function totally smoothly either. So this is not a unique problem. By the way, we've kind of gotten down near that line by having a whole lot of insurance. Our CP is getting pretty low. A fairly small fraction of our total expenditures are actually paid out of pocket. So this is just a simple example, but it kind of illustrates this idea that there are just a lot of different ways to clear healthcare markets. And I think we've probably overemphasized the role of money prices in economics. And in fact, it's interesting, that diagram never shows up in an economics textbook. We always have supply and demand diagrams that focus on price, but you could think of that happening in virtually every market, right? I mean, it's not, you know, healthcare isn't unique in that regard. So some lessons. Well, one lesson is, I think for the Greek healthcare system is where this official price is 0, you're probably experiencing some of these high wait times and some quality problems because of that decision to try to keep it a, quote, free healthcare system. But again, I'll just remind you, it's not free, not in a resource cost sense. So this is just talking a little bit about quality of care. If you were to try to raise the quality of care, it would actually increase demand and probably reduce supply because it's going to cost more to supply, you know, this higher level of quality. So that just kind of aggravates the shortages. Now, it may be less of a problem trying to raise quality over time if that quality has some longer term effects in terms of reducing the demand. So that's something to consider, but you really need to get into more of a dynamic kind of model to even talk about that. So there's really no easy solutions, and I think particularly when you have an economy that's struggling, and certainly yours is at the moment. Ours is doing better, but it's still not completely out of the woods. And I think a lot of economies are kind of going through this, how to maintain the social services that everybody values and is proud of in some ways, but you know, finding it more and more difficult in terms of the resources. So this is another part, and I'm not sure, how am I doing for time, Ari? Do I have a few more minutes, or? Okay, all right, please interrupt me if I'm taking too long here. So the question I'm asking here is, are there other games in town? Are there other ways that we might go about dealing with some of these problems, maybe in an innovative way, because it's not just Greece that's, you know, somewhat unhappy with your system, but I think a lot of countries are feeling that way. So let me talk about an old game that I'm familiar with. And in the US, there have been a lot of different attempts to control healthcare costs. Some of them have been at a national level, some of them have been at state level, some of them have even been at the level of the employer. And in fact, I'm going to talk about one of those plans that was actually implemented by an employer back in the late 1970s. So this particular plan was called the Mendocino Plan, or the Stay Well Plan. And what happened was, in the late 1970s, California introduced something called Proposition 13, which was an attempt to limit property taxes within local governments. Well, the local governments suddenly suffered a revenue loss, and so they had to find ways to cut their costs. And one of the things that came out of this was a plan that developed up in Northern California in a place called Mendocino County. Anybody been to Mendocino County? It's one of the prime winemaking areas of California. So oftentimes people, when they go to California, they end up in Napa County or Mendocino County. Anyway, they devised a rather simple plan that provided some incentives to their workers to not only reduce their utilization, but potentially adopt healthier lifestyles without necessarily sacrificing insurance protection. And that sounds hard to do, especially given what I was just talking about. But what they did was actually very simple and I think very clever. They had, and I'll give you the actual numbers here, they had what they called essentially a first dollar comprehensive coverage plan. There was, I think, a small co-insurance rate, so people paid a small fraction out of pocket, but for the most part, right from the start, their healthcare costs were covered by insurance. Well, that was costing $1,260 per worker. Now, that was a fair amount of money in those days. It doesn't sound so much now, but and the equivalent, if we just did, you know, kind of a price conversion, would be over $4,000. So you can see it wasn't a trivial amount that they were paying. But this particular employer, when they were faced with this cut in revenues, they actually went to their insurance company, which was Blue Shield of California, and they negotiated for a $500 deductible policy. Well, of course, what that means is the first $500 would normally be paid out of pocket by the patient, and then after that, the insurance would kick in. Well, that plan, clearly an inferior plan because it had this higher deductible, cost $780. They saved $480, almost enough to pay the deductible for people who, you know, actually experienced that. Well, what they did was they took this savings, the employer, they hung on to it, they put it into what would be called a self-insurance fund, and then they used that fund to pay the deductible for their employees. And essentially what they did was they said, look, we know you're going to face this deductible now, but when that happens, we'll pay this out of this fund. Fine, so you're just as good as you were before. You still have kind of 100% in coverage. But the really interesting part was they said, if you don't spend all of that $500 we're holding in this account, we'll put it into your retirement account. Right? So all of a sudden, now people, when they went to the doctor, would have to stop and think, well, do I really need to go to the doctor? Or is this something that probably is kind of self self-correcting. You know, I'm gonna feel better in a day or two. If the doctor prescribes some medication, do I really need the proprietary drug, or would a generic drug do? So it forced them to make some choices. And the other thing that was very interesting about this plan is it also prompted a lot of behavioral changes. There were all sorts of stories coming out from this group about people giving up smoking, cutting back on their drinking, exercising more, all the things that our doctors and other people try to get us to do, and usually not very successfully. And these people were doing it without any organized effort. They were doing it on their own. And the results were kind of interesting. So let me talk a little bit about those. But what I will do here is kind of show you that this really is structurally different than regular insurance. So this line that you see up here, well, first of all, this red line was essentially what they had before. No deductible, they were paying a small coinsurance rate, so their out-of-pocket expenses rose less than proportionately to their expenditures that they incurred. So Cap E is the expenditures, E sub O is out-of-pocket expenses. That's what they had, that red line. If they had just introduced this deductible without this rebate, it would have been that green line. Well, that's not better from the consumer's point of view, because now those first $500, my out-of-pocket's going to equal my incurred expenses because I've got to pay it all. After that point, then the insurance kicks in. So in this diagram, it's always better to be on a lower line, right? Well, what this Mendocino plan did was, if they kept their expenditures below 500, their out-of-pocket was actually a negative, right? Their out-of-pocket was that difference, and they got to put that into their retirement account. Well, you can see, for most people, this actually was a preferred arrangement. And it did seem to have some impacts. Forbes magazine, which is a fairly conservative business magazine, they got very excited about this plan. And by the way, this plan got a lot of public attention in about 1979 or 80. It was on the National Evening News a couple times, and it was getting a lot of publicity. And they did a little study, and they had, apparently there were 218 employees in this plan, and of those, 180 had claims below $500. So 180 of the 218 got some kind of rebate. Of those 180 that got some sort of rebate, there were 66 who had zero claims. So they got the full $500 back. So it appeared that this thing really was having some impact. Well, and again, I kind of got to this a little before, that there were lots of these stories about workers changing their behavior and altering their health habits. And again, I want to point out, that contrasts a lot with how we think people respond to conventional insurance. Under conventional insurance plans, we have what's called moral hazard. There's anti-moral hazard. People fail to take appropriate care to prevent accidents and so forth. There's ex-post moral hazard, where once something happens, they tend to consume more than maybe they need to because they know that it's going to be covered by insurance, right? Well, both of those increase healthcare costs. So it really did alter the structure, and I think that's important to keep in mind. Well, here's the postmortem. For all practical purposes, the Mendocino plan, in my mind, is sort of dead. They still have a plan called the Stay Well plan, but it's very different. They made no real effort to adjust these parameters of the plan, like this $500 target. I think it's still down around that level. And over time, even if you just adjusted it for normal inflation, it ought to be up around $1,600. So over time, the incentive has really weakened. And I think that's important to understand, that if you're going to go this route, you have to make adjustments as you go along. But it is something that I think is quite interesting, and I don't think there's any reason you couldn't do this with a national healthcare system. I mean, the principle is really a very basic one, and it's just a matter of structuring it in the right way. Good. Now, this obviously makes it more simple than it is because healthcare systems are inherently complex. And so I don't want to make this sound like it's too easy, but I think the idea is a very interesting one, and unfortunately hasn't gotten much attention. Another thing that has happened is that
we have a minute, Dennis.
We need to end.
Yeah, if you.
Okay, I think this is the last slide actually. The other thing that has happened is that the insurers' resistance to these plans has led them to basically kind of abandon them to the extent that they could. And from their perspective, you've got to understand, even if they had made more money on the plan in terms of, because they were getting a smaller premium, but they're also paying out less, right? But the other part of insurers' revenue stream comes from investing the cash flow from premiums. So any policy or kind of policy that reduces that cash flow kind of reduces that source of earnings. And so I think that's one of the reasons they resisted this. We have this paper that I refer here to where we show that its potential, or it could be structured in a way that both parties benefit, both consumers and the insurers. But unfortunately, the insurers haven't bought that story. Anyway, this is just, again, saying some things that I think I've said, although the top one there, I had a student, Archita Banik, who did her dissertation recently, and she was kind of interested in this plan from the perspective of developing economies, because they have difficulties insuring their populations, and this might be a way of kind of getting around some of the problems that they face. Okay, I think that's pretty much it. This is some other references here that you could look at if you're more interested in this in a little bit greater detail. That's pretty much it.
Okay, thank you very much. Bakude. Thank you very much, Dennis. That was really very, very interesting, and that's why we were polite enough to leave you.
I'm sorry it went a little longer than I
the
anticipated.
The next speakers will try to.
Okay.
But anyway, it was really, most of it was a kind of economics, health economics approach, so it's difficult for us to probably to raise some questions on that because it's a seminar-wide. Okay. But we'll leave it at the end. I think we have to go ahead. There were many impressive, and especially I noted the one that you said in this Modesino type of example, that the savings, they could be transferred to the retirement account.
Yeah.
Which is a very interesting type of policy.
Yeah.
The only thing is that what we would say that even that transfer would go to a specially cost code for covering health problems, because during the retired days you have more health problems.
Right.
So that's somehow.
Yeah. You should keep in mind that was just their choice to do it that way, to put it into the retirement account. There are dozens of other ways you could do that. I mean, you could pay it out to people in cash, right? At the end of the year, if there's money in that account, you could pay them in cash. So there's lots of alternatives, and I think that's another area where people could be very creative in the way they structure those accounts to accomplish whatever other goals they're trying to accomplish. But.
Okay. So if you have something to really to ask during the interval, Dennis, after that. Oh, there are questions here. Oh, really? These are short questions, they need short answers.
Yeah, well, let's see. So is total absence of cost sharing a matter to discuss politically, especially for lower stratus needs for health care, if we manage to save money from excessive or badly spent expenditures? I think, obviously, you know, governments have to make choices about how to treat individuals, for example, from different income classes. And I think most governments make a decision along the way that they're not going to treat everybody in exactly the same way. And I personally think that's a sensible public policy. So it's conceivable that if you were to implement this kind of plan, that might be tiered in some way. There might be different parameters for different groups. So that's something I haven't given a lot of thought to because I've always just kind of presented it in this fairly simple form. But I don't think it would be all that difficult to perhaps model that kind of arrangement where you have a plan that has some different sorts of parameters depending on the group that you're talking about. And I would think that income would be a place to start in terms of how to do that. Is there a cutoff for net price costs that will translate to optimum or minimum health indexes? So I guess, let's see. I guess maybe you're asking is there a point where, you got to keep in mind these net prices are what the individual is paying out of pocket. The full price is what the provider is getting. So it's not clear that just because the net price is lower or goes down because of insurance, that somehow the provider will get less. In fact, in a conventional insurance plan, as the fraction paid out of pocket goes down, that demand rotates and the price that the provider gets goes up because of the increase in demand. So certainly, I think there are consequences for providers in this sort of plan. But what was interesting in Mendocino County, I've got to tell you a story. When they did this, and they were running it for a while, the employees, once they understood it, they were just happy as could be. And there were all these stories about, people taking better care of themselves. It was really kind of an exciting thing. The employer was delighted because not only were they buying cheaper insurance, right? But they were holding the side fund and earning interest on it. So they were really happy. And their employees were, were healthier. The doctors in town didn't seem to object. They had, they didn't seem to notice a huge reduction in their own business because they weren't dependent on this one small group of employees. Now, maybe if you did this on a wider scale, it would have some impacts on them and they would object. I don't know, but they didn't. The only party that objected to this was the insurance company that agreed to it. They didn't like it, and they didn't like it because it reduced the premium, and they had less money to invest on this cash flow. And in fact, they disliked it so much that about a year later, they commissioned a study to develop some bad findings that would allow them to say, we'll never do this again, okay? So it was kind of interesting, the response to this.
Could we really close it?
Yes,
Dennis,
absolutely.
Please, yeah.
Thanks.
Okay.